I'm Dr. Digmajan. It's August 29th, 2023. We're here at Duke Spine Institute. Our patient comes to us from Canada and he has bad back pain. There are 2 bad discs in his lower back damaged, and we're going to go in there and fix them today. You can see on the MRI, bottom corner of your screen, there's 2 dark discs. That means they've been damaged. He's a young man, and honestly, he shouldn't have dark discs, but clearly he had an injury to the discs, having pain from them. We call it discogenic back pain. Anytime you have pain from a structure, you can call it pain from that structure. In this case, we call it discogenic because it's coming from the disc. Shot? If the pain was coming from the facet joint, we'd call it facetogenic. So the first step in this surgery is to get into the bad disc, and that requires placing a needle. Shot? And I've got to do this carefully because you're going past some area of high-priced real estate. Shot? Are you okay?
How are you doing, my friend? You okay? Yep. Are you having any pain down your leg?
Shot?
No pain down his leg, you said.
AP? Wonderful. So there are not many surgeons in the world that can do endoscopic surgery, and there's even fewer that can do transforaminal endoscopic, and there's even literally fewer, probably I'm the only one, that does L4-S1. L4-S1 is a challenging disc to get to. It's the second most common disc to cause pain, and it's the hardest disc to access. And the reason is because it's in a very peculiar place. It's located at the bottom of your spine, and there's a lot of things there that block access to it. Shot? Are you okay? Look at that picture, man. That's like, what are you doing to get such a clear picture? AP? I think part of it, yeah, he's crushing it. I think part of it is the patient's in great shape. Doesn't have a lot of excess tissue. Lay still. That looks good. Yeah, I'm right up against the facet. Any pain? Burned as I can't hear him. Any pain?
No pain.
Might feel a little bit. That's your first bad disc, all right? Num num. Now that we're inside the L4-S1, I always start with 5-1. And if you do endoscopic surgery in the spine, in the lumbar spine, you should always start with 5-1 if you're going to go transforaminal. Now, there are endoscopic surgeons doing translaminar, a lot of them. It's called the UBE. It's being taught over in China, Korea, India. It's a horrible procedure, and because they're still destroying the spine. They're actually cutting through the bones and ligaments in the back of the spine. I don't recommend it. That's not the kind of endoscopic surgery we're doing here. Shot? The type of endoscopic surgery we're doing at Duke Spine is the more advanced, less invasive, safer type of endoscopic surgery. You're doing great, Shot. We're almost done. We're going to put you to sleep in a minute, Shot.
You're doing great, my friend.
You're doing great. Shot. So I've gone from being a screw jockey to being a needle jockey. I used to make fun of Dr. Patel, who's our interventionalist here, our first one, the main one, that he was a needle jockey. You know, a needle jockey is someone who moves a needle into small areas of the body to access certain places. In this case, the discs. That's perfect. You can actually see some scoliosis developing there, right, Jordan? See he's kind of collapsing on the right side? All right. Well, are you comfy? Shot? He's definitely not happy with me. Shot? All right. Any pain?
You have any pain, sir?
So this gentleman, how long have you had back pain? I didn't hear. 15 years?
15 years, yes.
15 years of back pain. Okay. So you guys see this, Sanjay? Lower back pain.
Yes, we see it.
15 years. Now, when I saw him, I asked him, where is your back pain? And he pointed to this, said, put your finger on the worst spot. And this is what he pointed to, right here, this area. And I looked and said, what's here? And that's when I looked at the MRI and I realized he had 2 damaged discs. Are you comfortable? Any pain? How high does that go on a scale of 1 to 10? What's the worst it gets? Yeah.
Give us a number 1 to 10. 6 to 7.
7? Is that where you get back pain?
Yes.
All right. He must be having some good pain meds. So it's concordant. Is it better now?
Is your pain improving? Not yet.
It still hurts? All right. Let's give it a minute. So during a discogram, I'm injecting dye a little bit under pressure, and he experienced pain. You can see from the x-ray, there's a huge tear in the back of his disc. Shouldn't be there. This dye should be contained within the center of the disc, but it's leaking out through a big tear. Is that better? All right. How bad is that on a scale of 1 to 10? How high does it go? 8? So, all right, he's stoic. It's okay, there's nobody to impress here. It's concordant. Is that where you get your pain typically? All right, when you wake up, your surgery will be done. You get to go to sleep. I want you to count out loud for us in Canadian. Can you do that? Since you're from Canada? Let me hear you count. 1 to 100. All right, he's counting. This is where you do the truth serum. You get to find out like where people really are from. You know? If they start counting in Russian, you know they're a Russian spy hiding out in Canada. I'm just kidding. He's not a Russian spy. At the end of the day, you got to use your imagination. All right, let's show our audience why do these disc herniations, why do they cause so much back pain? Show the educational video for us, would you? Welcome back. Now you can see from that video that the cause for back pain when you have discogenic back pain is actually inflammation. Guys, we need the pumps on. We can't wait. They should be ready to go. It should be ready to go. So the cause of back pain is actually inflammation that comes from a tear in the wall at the back of the disc. And if you look right there, you can see some of that pink material we were just showing you. That's not blood. That's actually blood vessels. And it's called granulation tissue. This is not a very good one. We have much better ones that we've seen before. And every patient is different. You never know what you're going to find. Some of them have a lot of granulation tissue that you see during surgery. Others, you don't see it so well. But I can already see the scar tissue here. You see the blue and how it's kind of, hey, how is he doing? Good. I just thought I heard him talking. No? All right. It must have been my stomach grumbling. Okay. You hear that? That's the nurses? That was the nurses. See all this stuff right here, folks? Right there. That I'm lasering with the laser? That is extremely unusual. It's scarred up disc. Okay? Scarred disc. It's scarred. It should not be scarred. Normally the nucleus is kind of soft and fluffy. This is firm. It's like cheese. Even thicker than cheese. Maybe Canadian cheese.
We have a question.
This is what?
Just adjusting his own.
This is, if you were talking about cheese, we'll take the question in a moment. Since I'm on the subject of cheese, clearly I'm hungry. This would be kind of like a mimolette, as opposed to a pavé de Nord. It would be firm, waxy, but delicious nonetheless.
I didn't know you were a charcuterie connoisseur.
I love cheese. I don't know why. The best.
See that study that came out? That people that eat cheese every day, I think it's a 10-year longer lifespan.
10-year longer
10
lifespan.
years.
There you go.
They say how bad cheese is for that.
Well, I think
I have a sugar that's
excessive.
You live 10 years longer than you expected.
Good. I want to live 10 years longer. I've got a lot of work to do in those 10 years. I love fruity nutty bread with some cheese.
So you like the figs and the dates inside of the bread.
Oh yeah, figs, dates, a little bit of nuts. Holy mackerel.
Where do we go for that around here?
I have no idea.
They gotta go to Vegas for that.
No, I don't know where to go for that. I don't think we have it around here. And it's probably a good thing. I'd be a lot fatter than I am.
You know, the Dutch, where my family's from, they're very big into cheese with everything else.
Really?
They eat it at the end of everything.
I didn't know. You know, I've been to Amsterdam and
Notice all the cheese?
I didn't know, I kind of knew the Dutch liked cheese.
Cheese and chocolate, world famous.
I didn't know. I didn't know the Dutch were so crazy about cheese. Now, when I went to Amsterdam, I noticed there's a lot of grilled cheese sandwiches you can buy. And I then realized after going there a few times, as Arias was racing for Van Amersfoort, that they have a lot of grilled cheese sandwiches. And that's what I ate when I was there, a lot of grilled cheese sandwiches. I like it. My grandmother taught me that. She was she was half Dutch. Yeah. All right, we'll take the question. I'm sorry. Dr. Berndes and I are talking about cheese. We got a little distracted. Go ahead, Henry.
The question comes from ERMS on YouTube.
ERNS.
Yes, and they asked, Hey doc, what's the reason for the rising spinal disc problem apart from sedentary lifestyle? Are we evolving or?
Yeah. It's a great question. I think, so the question is, why, doctor, or why are we seeing so many problems with the discs? I think it's a combination of things. First of all, you have to ask, are disc problems a problem of younger or older people? And generally, it's a problem of older people, okay, in general. The vast majority of patients with disc pain or disc problems are going to be older, like 45, 50, 60. And human beings are living longer than we've ever lived before. So as more of us live longer, you're going to see more incidences of diseases that affect older people, like disc problems, okay? Second of all, there's definitely a genetic predilection or, I don't know, genetic basis for symptomatic disc problems. So for some reason, the people that are living longer also happen to be the ones that have a higher incidence in their families of symptomatic disc problems. So we're seeing more for that reason as well. And then people are also more active, more athletic. There's driving cars now. Like, think about it. Back in the 1920s, there weren't a lot of cars. So, 100 years later, people are in car accidents more often. We're getting into more car accidents, more athletic injuries, more sports injuries, and slip and falls. And so as we become more active as a society, doing more high speed, skiing and driving and bicycles and, kind of activities where you can be injured during those activities when you have an accident, that's contributing as well, because disc injuries are always traumatic. They're always related to some trauma. So we got more traumatic injuries happening now than ever before. We've got older people than we ever have before. We've got a prevalence of genetic predilection for disc injuries that exists now more perhaps than ever before due to selective, evolutionary selection. Perhaps those disc traits are tied to other traits that are favored.
I would agree that car accidents are way higher.
Yeah.
When you have more cars on the road, there's much more road construction.
Yeah.
To try to accommodate the volume of cars.
Yeah.
Remember in the old days, every family had one car,
Oh yeah.
and they had a one-car garage. Like in my old neighborhood, every house has one-car garage.
Yeah, and
House has just two cars.
yeah, but not only do we have more cars, but we're driving them faster, right? Everyone wants horsepower. Everyone wants speed. And then there's other factors. We've got MRIs now since the 80s and 90s that we're using MRI scanners more and more to diagnose these conditions. So I think there's, many factors involved in the higher incidence of disc injury problems in society. I think some of it is technology driven with respect to the cause of the problem, but also the diagnosis of the problem.
Also, the construction workforce has increased a lot, exponentially.
Yeah.
The labor force,
Construction injuries, sure.
yes, I think that's really,
Yeah. So I think it's multifactorial. I don't think there's one cause. I think there's many contributing causes. Good question. Yeah. Good questions.
We have another question.
Sure.
This comes from Mrs. Ryan Paya on YouTube.
Hello, Ryan Paya.
They asked, "Hi doctor, is RF is recommended for a slip disc? Does it make my nerves dead of what? And what is the side effects?"
Yeah, great question. So RF stands for radio frequency. Radio frequency is a treatment that is very popular right now and very common. It's called radio frequency ablation, or RFA. And the treatment is really designed for pain that comes from facet, F-A-C-E-T joints. So there's basically two types of joints in the spine. There's a disc and there's a facet. And the disc is the most common cause of back pain, but the facet is the second most common. And patients with facet joint pain, the best treatment in the world right now for facet joint pain is rhizotomy. It's basically deadening the pain nerve to the joint. Now, the way that it's been done all these years is called radiofrequency ablation. And that's a pain management procedure. It's done by pain management doctors. But there's a new way of doing it that's far superior to radiofrequency ablation. And it's called Duke plasma rhizotomy, or DPR. And I'm the one who invented it and pioneered it. And we've been doing it here now for around a year. And we've had amazing results with that treatment. Virtually every patient we've treated, we've been able to get rid of their facet joint or sacroiliac joint pain. And now we're applying it to hips and knees. And this week we'll do our first shoulder. So we've been doing hips and knees with people who have, arthritis of the hips and arthritis of the knees. And they're being told by their orthopedics they need knee replacement or hip replacement. And instead we've been treating them with this Duke plasma rhizotomy, and we've been able to get rid of their knee pain about 95% plus, and it lasts as long as we do it right. Our first couple of patients, we didn't really have the technique down perfect. The first one was actually my mom, and since then we've done probably 20 of them, and we've gotten the technique down with the knees really good to where the patients are getting almost 100% of their knee pain gone, and it doesn't come back. So this whole concept of rhizotomy, I think, is going to be really big in the future in terms of treating pain without doing invasive surgeries, okay? The Duke plasma rhizotomy that we developed here is going to replace all the knee surgeries, all the hip surgeries, all the shoulder surgeries. It's already replacing the SI joint treatments and the facet treatments. And I think it's going to end up replacing all these joint surgeries that are currently being done by orthopedic surgeons. And it's funny because, Florida is a big state for joint problems, and there are lots of Medicare patients here with bad knees, bad hips, and kind of like, when you go to like South Africa, right, and you see the great white sharks swimming in the water, you ask yourself, why are these great white sharks here? Anybody know? Let's see who watches Shark Week. No, not migration. That's whales. Sharks do migrate, but there's a reason. Anybody? Are you kidding me?
Is it water temperature?
No, it's seals. They're prey, what they eat. There's tons of seals, Cape fur seals in South Africa, Australia. So these sharks are there for their meals. And when it comes to spine surgeons, orthopedic surgeons, they're migrating to Florida just like the great white sharks migrate to Africa to eat the seals. They're migrating to Florida to do surgery on all these Medicare patients here, on their hips and knees. Anyway, the point I'm trying to make is very soon those surgeries won't be necessary anymore. Knee replacements, hip replacements. So they would have migrated to Florida for no reason. And they can just migrate themselves back to Philadelphia. Sorry for my... We got another minute on this one. This is a bad disc. I mean, I'm surprised. He's so young, but he's had this for 15 years, as he said. We're almost done. The problem was getting into the disc. I had trouble. It was like the facet was pushing me laterally, and I had to get in a little bit lateral, but I'm trying to make my way medial. Anybody see the Meg 2 movie?
I have not, no.
Yeah, it's not one that I'm going to be going out to see either.
Understandable.
It's just so kind of stupid with, you know, Jason Statham driving around in a jet ski with a megalodon. I mean, how do you explain that? That's a good sized piece there.
See the movie Black Demon?
I didn't watch that one either. I mean, all these movies about sharks, they're so unrealistic. It's hard for me to get excited about them. Since I dive with sharks, and I have for years, I understand their behavior a little better. And these movies are just so unrealistic that it's hard for me to watch them. The what? The magnets. Yeah. Yeah, I've seen them. They work until they don't work. You don't hear about the ones that don't work, right?
What do they use them for, the license plates that are in their stomach? You just
No.
repels or whatever.
It doesn't repel them. Look, I've seen them. I know about them. I talk to divers that dive with sharks and have used those magnets. They mess with the shark's organs that sense magnetic fields and around their mouth. And basically, they don't always work. So that's the problem. You never know which shark it's going to work for. And you don't want to be finding out that it didn't work for that one shark because you won't make it out of the water to talk about it. You know what I mean? No, most sharks are fine. You know, they don't bother you. Like black tips, white tips, gray reef sharks, bull sharks. Even bull sharks, for the most part, don't bother humans. But I would never want to be in the water with a gray white. And I've seen people in the water with gray whites. I think those are juvenile gray whites. They get lucky. I know there's this one woman that dives with a giant female gray white. I would not do that myself. Free dive with a giant female gray white. I wouldn't want to dive with a tiger shark. If I saw a tiger shark, I'd get the heck out of the water as quick as I could. Okay? You have these people that are like pushing the tiger shark away with their hand. They think the tiger shark is this slow animal. That's the thing that people don't realize, is just how fast sharks can actually move when they want to. You cannot outswim a shark. You can't even outreact a shark. And as soon as there's some blood in that water, they become a completely different animal. I've seen it. Thanks. They move so fast. All right, laser. We're just about done. This is taking me a little longer than I expected. But we've got a lot of herniation out. There was a lot more than you could tell right away. And there's still some stuck in here. So I want to have a good look here before I'm done. Is that you or? Any more questions? It's a lot of fat here.
Yes, we have a question from Mrs. Ryan Paya once more on YouTube.
Sure.
And they asked, in the future, does RF make more damage on my spine? Sorry, Doc, I'm about to do it in a few hours, but I'm still 50-50.
Oh. I didn't really hear the question. Maybe you can repeat it.
No, yes, of course, no problem. In the future, does RF make more damage on my spine? I'm sorry, Doc. I'm about to do it in a few hours,
So
but
she's
I'm still 50-50.
so she's asking me if RF is a good idea.
I would believe so. Would it make more? Yeah, would it make more damage
Yeah.
on the spine?
Yeah, I think that, okay. So to answer your question, if you have pain from a disc, then the RF will not work. If you have pain from a facet joint, then the RF could work, and it will only work temporarily. It's just a matter of time before your pain comes back. So I think it's okay to do, but I wouldn't count on getting too much relief. How are we doing on irrigation? You already did? Yeah. It's like the never-ending herniation. I'm just having a hard time gripping the herniation with this grabber. Laser. Any more questions?
No current questions.
Well, his disc is more damage than I expected, based on his MRI. You can see the extent of damage, but we're just about done. Remember, we're never going to get 100%. We can't. It's not possible. We're trying to get as much of the symptomatic part of the disc herniation as we can. That looks pretty good. That's it, I think. Do one more grab. I think that's good. Scope off. Keep the questions coming. So we just put a little betadine antiseptic down there. We do that for every disc. We take a lot of precautions with these surgeries, trying to keep people from getting any complications. One of them could be an infection. And we do everything possible to prevent complications and infections, and one of the things we do is we irrigate the wound when we're done with antibiotic irrigation. All right, once we come out, I put some pressure on the muscle. I don't want any bleeding into the muscle. Bleeding is an inevitable part of surgery. It's just a matter of how much bleeding that becomes the issue. Shot? All right, the next disc is number 4-5. We finished 5-1. Shot. We're going to head down this guide wire once again with our dilator. We broadcast our surgeries live so people can actually see what's being done. We want people to see what's being done. We don't want to hide what we're doing. We have no reason to. Shot. Let me pull back the guide wire just a little bit. Shot. Great job. We're going to be putting our tube in, and I'm advancing it with the hammer. Perfect. That should be good. Now that we have the tube inside the tear where the herniation is, I've actually pushed some of the herniation back into the disc. We're going to go in and get it out. And at the same time, we're going to clean up the tear. All right, we got about 15 minutes, I expect. We should be done. If you have questions, feel free to type them up for me. I'm happy to answer them for you. Shot or not shot? Sorry, scope picture. All right, looks good. There's a piece of herniation. Unfortunately, his herniations are the type that, you know, want to come out in about 30 different pieces. So I can't really get a nice big chunk out. I'm trying, but it's not working. Maybe. I'm going to start with the laser. The laser actually is really good at, especially soft herniations like this that are not so scarred up and calcified. It can actually take them down pretty quick. See, there's a little bit of scar tissue, but not much. Sometimes it's just a matter of releasing the herniation. How's irrigation? So the whole surgery is done through a 7mm or 1/4" incision. And there's virtually no downtime. These patients all end up back on their feet by tonight, and they come walking in the morning, and their pain from the surgery is usually gone. About 10% of our patients end up going home with some discomfort that, you know, is from inflammation related to the treatment or pre-existing, and they usually it just takes time. They heal slow. Not everybody heals equally fast. Yeah. Any questions?
No current questions.
Let's show our audience how the Duke laser disc repair works.
Disc herniations are a common cause of chronic back pain.
All right, welcome back. You can see now how the Duke laser disc repair works. We're using a laser and an endoscope to find the annular tear and remove the pieces of herniation, cleaning out the tear. We're not doing a discectomy, we're not doing a laminectomy, we're not doing a fusion, we're not putting anything in the body that's unnatural. It's completely natural surgery. And what I mean by natural, it's not natural to have surgery, but it's natural in terms of we're not adding anything unnatural to your body. We're not leaving in bone graft, metal, anything. See, the body has the ability to heal as long as you help it a little bit. In the case of a herniated disc, the disc wants to heal, but it can't because this jelly here, this nuclear material, is stuck in the tear. And if I go in with a laser, I can clean it out, get rid of it, and that allows the annulus in the disc to heal. This laser just isn't taking out the pieces, Luis. I don't know if the tip has an unusual shape. It's delivering the laser energy in a very unusual pattern. I would refracture the tip. See, normally it would cut through a piece of herniation like that and release it. But I have to go back in with the grabber now to release it. I'd say 3 minutes. None of these pieces are coming out on their own like they normally do. I don't know. I don't know if that's it. Any more questions?
No current questions.
All right, if you want to get your questions in, this is the time to do it, folks. We're going to wrap up our broadcast in about 2 minutes. As soon as I finish this disc, there's the last of it. Maybe 3 minutes. The way this disc has been going, hasn't been very easy for me.
We have a question.
Okay?
This comes from Mrs. Ryan Paya, once more on YouTube.
All right.
And they ask, what is that white thing that you are drilling, doctor?
That's a herniated disc. It's a piece of herniation. All of that is herniated nucleus pulposus. It's just, you guys are seeing it on a almost microscopic scale because everything is so magnified. But all those things we're taking out are pieces of herniation. A lot of people think, oh, the herniation is one piece, but it's not. It's many pieces. Sometimes I have to chop the pieces down from big to small to get them out. Almost all of them are scarred right to the annulus or to each other. And I have to free them up. And the only way to do that is with a laser. That's why the laser is such a valuable tool. It's the only tool that lets you remove all this stuff efficiently and properly. Those metal grabbers don't work. They don't work well at all. They're good for pulling out loose pieces, but they're not good for releasing these pieces here. For example, these pieces that are scarred. I got about a minute left, I think. A little bit hazy. Not sure. What do you think, Luis? Think it's the lenses or just some schmutz?
Maybe it's too cold. I mean, the water's too cold. When they just switch it right now.
You guys see that little vein right there? It's pretty cool, huh? Yeah, see that little vein? A lot of people don't know, but the laser can actually stop bleeding. It cauterizes blood vessels. This is really the back of the disc. It's quite nice. We're able to see that so nicely. One minute. All right, any other questions from our audience?
No current questions.
Okay, well, we're gonna end our broadcast in just a minute. I'm pretty much done here. Let's see the grabber. Some of these are hard little pieces. That looks pretty damn good.
Lights on, please. Thank you.
Thanks for joining us. We're pretty much done. Scope off. I'm going to put a little more antiseptic. And then we're going to take the endoscope tube out. We'll put a little staple, Luis, right? All right. Well, it's been an enjoyable day, and our patients have done quite well. Everybody's gone except this patient. Home, that is. This is outpatient surgery, in case you didn't know. Our patients don't go to the hospitals. We keep them here and give them an hour recovery and then send them to their hotel. Great job, everyone. I'm going to put a little pressure on the muscle here just to keep it from bleeding. I one time had a patient that the blood pressure spiked around this time, they developed a little bit of a blood clot in the muscle, and he had pain in his muscle literally for 3 months after the surgery, because the blood clot breaks down in the muscle and it irritates the muscle and just causes pain. Doesn't do any permanent damage. So I learned after that time to keep the blood pressure under control, but also to put pressure, you know, prevent a blood clot. You can actually feel a blood clot. I don't feel any blood clot. It's soft. Feels like a nice piece of steak. All right. Great job, everyone. Until Thursday, hopefully, unless the hurricane takes us and shuts us down Thursday, we'll see. We'll see you all Thursday. You can end our stream.